Hi, and thanks for joining Providence Coding webinar series. Today we'll be reviewing clinical documentation query strategies and a case study involving toxic metabolic encephalopathy. I'm Ben Saverborn, and here's a little background information about me. I currently hold an RHIT and CCS. I have over 10 years of experience in HIM, inpatient coding and auditing, and clinical documentation improvement program implementations and education. Today we'll be talking about queries and query strategies, and specifically a case study with toxic metabolic encephalopathy. So let's go over first the query components. Whenever writing a query or discussing with the provider, you always want to include first the case summary. So something like patient presented with, it just gives a context for the query. Secondly, you want to give the clinical information, so include pertinent, supportive, and conflicting facts and quotes, include treatment where applicable, and then you want to provide the specific question, so be very clear on what you're asking. So it could be a yes or no question, it could be multiple choice, and open-ended. So some of the best practices is you should always use complete sentences when querying. So sometimes it's easier, or when physicians speak to each other, they'll use shorter sentences or abbreviations. But whenever you write a query, you want to use complete sentences. It's actually easier to read. You want to include brief supporting details, pertinent positives and negatives. So some of the mistakes I've seen in the past is when querying for, say, sepsis, you'd only include the evidence that supports sepsis, but you also want to include things that would maybe go against that diagnosis. Like, for example, if the blood cultures were negative, you also want to include that so you give the full picture of what question you're asking. So the pertinent positives may support query opportunities related to patient acuity, severity of illness, or risk of mortality. And the negatives, they help support the rationale for why a query is being placed. So for example, if there's documentation of acute MI, but there's normal troponins. So if you don't include the normal troponins, then they're going to say, well, I don't think this patient has an MI. But you want to say, well, this is what you're trying to clarify, that the patient has a documented AMI, but then the troponins the levels are normal. So you're just clarifying what's going on. If it's there's something wrong with the lab or they have to repeat it. So you're just presenting the whole picture. You don't want to just present information that supports the diagnosis you're trying to clarify. You also want to include the negatives. Of course, do not copy and paste content from the medical record. Well, parts of it you can, but you definitely don't want to copy a lot of it, because then it becomes too lengthy. Because a lot of times the medical record includes lengthy and sometimes extraneous information, and you really just want to include exactly what's necessary and nothing more. Again, I mentioned abbreviations. They're sometimes difficult to read, and it makes the flow a little more difficult when just reading through a query. So some of them we actually use, like COPD. Those are terms people actually say. But like hypertension, you don't often hear HTM. You just hear patient has hypertension. Sometimes you'll hear CAD, so that's acceptable. But the ones that you don't usually hear spoken out or in terms of acronyms, you don't want to use those. So a good example is you can use COPD, but say hypertension, you want to say hypertension rather than HTM. So today we're going to really talk about one of the most difficult queries or controversial queries is toxic metabolic encephalopathy. So let's first start with the definition. It is an acute toxic metabolic encephalopathy which encompasses delirium and the acute confusional state in an acute condition of global cerebral dysfunction in the absence of primary structural brain disease. So let's start with the beginning of a case. A patient comes into the ED on 12/22. The chief complaint is general weakness and confusion. So any patient coming in with weakness, confusion, mainly the confusion, there could be a question of toxic metabolic encephalopathy. It's very early, but it's the first sign. There's something there's a confusion or altered mental status on admission. You also want to look for the symptoms of when they began. So if it's a recent acute change, then that supports TME. So I'll just, and rather than say toxic metabolic encephalopathy, I'll just abbreviate the TME. You want to check to see when this change occurred. If the patient has a baseline altered mental status, then that would not support or not likely support TME. But if this is an acute change, then that more supports TME. TME is an acute condition. It's an acute change from their baseline. So in this particular case, the patient's confusion began yesterday. Mental status is not at baseline. So that a lot of times in many conditions you want to look at that. Do patients have long-standing conditions, chronic conditions? If that's the case, then most likely it's obviously chronic. But if it's something new, then it could possibly be acute, and in this case, maybe TME based on the presentation. Also, this patient was alert and oriented ×2. So ×1 is person, ×2 is place, third is time, and fourth is situation. So this patient was only alert and oriented to person and place. Next, you want to look at the treatments and the labs that are looked at. So you want to look for treatment of infections and or electrolyte abnormalities. Both can cause TME. So a patient comes in with altered mental status, but what's causing it? Is there a potential cause of it? So you see right here, the patients were treated with potassium and magnesium. So they're obviously correcting their electrolyte abnormalities, which could contribute to TME. So already you want to say, well, a patient comes in with symptoms. Is there any conditions that would cause that change in altered mental status? And right away you see that there's a potential cause of electrolyte abnormalities, which are treated. The next thing you want to look at is what studies are initiated. So here, right away, if a patient comes with altered mental status as an elderly, they're going to be questioning if there's a stroke. So the first thing they order is a CT of the head without contrast, and notice that there's no acute intracranial process. If there was, say if they had a stroke, well, that would most likely explain why the patient has an altered mental status. But in this particular case, there's no stroke, so TME is still a possible diagnosis. Now let's see what else is documented. And so as I mentioned, there's no intracranial process, so TME could potentially be the cause of AMS. And infections and electrolyte imbalances are common causes of TME. So this patient has altered mental status, UTI, hypomagnesemia, and hypokalemia. The UTI could possibly cause the encephalopathy, and the hypomag and hypokalemia could also as well. So already we're building a case for potential TME. Now moving to the H&P, this patient has weakness, lethargy, altered mental status, which again could support TME. The clinical presentation is consistent with infection sepsis, which is one of the main causes of encephalopathy. So this patient may have UTI, sepsis, electrolyte abnormalities. Now, is there a reason that's causing this altered mental status? So patients who come in with UTI and sepsis not necessarily have an altered mental status or an acute change from their baseline. So this case could potentially be a candidate for sepsis with TME as a MCC. So again, more support for the potential for TME. They treated with levaquin for the infection, the magnesium sulfate for the hypomagnesemia, and the KCl for the hypokalemia. I also highlight here that there is no history of smoking or alcohol usage, because if this patient, say, was inebriated, then that could be causing altered mental status. So everything you want to look at what fits in this picture. There's no diagnosis here for, say, alcoholism. Or drug use, which could explain the TME or the altered mental status. So TME is still a potential diagnosis. If they said, oh wow, this patient has alcohol levels is very high, well, then maybe you have the cause for the altered mental status right there. So AMS, which is not, so they're not at the baseline. So if the patient's baseline was altered mental status, then you would think, well, maybe they have dementia, so that could possibly be the cause. But this patient's baseline is not altered mental status, and the patient does not have dementia. Also, the patient was noticeably lethargic, which also would support it. The urinalysis shows UTI, so there's a source of infection, which could also cause that altered mental status. Also, toxic metabolic encephalopathy. The chest x-ray, so they did a chest x-ray just to see if there's a potential for pneumonia. And the chest x-ray was clear, which narrows the etiology of the infection to the UTI. CT was negative for stroke. However, there was the question of myeloma, which could be causing the altered mental status, so it's something you want to take into account. And very important clinical key here is TME is a diagnosis of exclusion. So in other words, if there cannot be another etiology found, then TME may be the diagnosis. So that's a diagnosis of exclusion. And going to the assessment and plan, sepsis is diagnosed very clearly, sepsis secondary to UTI, also noted to be lethargic, weak, altered, and that's probably a recurrent source, which is likely the urinary system, so it's a very strong note. So clearly patient has sepsis secondary to UTI, but also with weakness, lethargy, fevers, that can all be explained by the sepsis. But how about the altered mental status? Would this be explained or supported by a TME diagnosis? Also noted were the hypokalemia and hypomagnesemia that was diagnosed and treated in the ED, and it was carried over to the H&P. So those can also contribute to the altered mental status. Myeloma was noted, so just another differential that could be in the mix. And then on day 2, the patient's altered mental status is improving, which you would expect once you correct electrolytes and also start the antibiotic treatment. So again, just because it resolves quickly does not mean it wasn't there. And the question is, could the provider further specify their altered mental status to be due to TME in the setting of sepsis and UTI? Lethargy was also improving. And then the patient's noted to be alert and oriented. And this is the remaining part of the discharge summary, and just really reiterates what the patient had. More specific bugs were found with the gram-negative rods. And also note that the patient had multiple organisms growing, so a pretty bad infection. The sodium-potassium levels returned to normal by the time of discharge, so that was corrected. And just taking a look at the labs, the white count was pretty elevated. I look on 1228, all the way up to 28,000. Looking at the potassium on admission, it was 3.3, so just slightly under the reference range. And also the magnesium was low at 1.4 milligrams per deciliter. So those were corrected by the next day. So let's look at some of the clinical keys of toxic metabolic encephalopathy. So it encompasses delirium and acute confusional state. This patient potentially could have had that. TME is a diagnosis of exclusion. So once other conditions such as stroke, alcohol withdrawal, etc. are ruled out, TME can be considered. And this is the source of this is Up to Date, which is a highly respected source. And it's really that's the way TME is diagnosed. Where everything else is ruled out, then TME can be ruled in. The most common causes of TME are sepsis, uremia, renal failure, hypernatremia, hyponatremia, hypocalcemia, hypomagnesemia, which this patient had, and hypophosphatemia. So the way to treat TME is treat the underlying cause. So in this case, the electrolytes were corrected and the infection was treated. So this particular patient could potentially have had TME. Also, check to see if there's an acute change from the patient's mental status baseline, since TME is an acute condition. So if you're talking about your chronically ill patient with dementia, then it's very difficult to say, well, do they also have TME superimposed on their baseline dementia? It's very difficult to say in those cases, but this one, it's a little more straightforward. So I think if this was to be queried, this is a strong chance that the physician would consider TME as a secondary diagnosis. Now here's a query example of how we could potentially query the doctor. So we would start with the history, for the context. So this is a patient. Patient is an 84-year-old patient presenting with lethargy, weakness, and altered mental status due to sepsis of urinary source. Noted to be alert and oriented ×2 in the ED, which improves after IV Levaquin, potassium IV, and magnesium IV. Please clarify if the patient had the following. So ask if patient had altered mental status due to encephalopathy caused by sepsis, just so you link it all together, because truly sepsis, it was a sepsis picture, a septic picture, but is there also a question of sepsis with encephalopathy to explain the altered mental status? Or is it a patient had altered mental status due to other etiology, where the doctor just doesn't feel that encephalopathy was clear enough? Or the patient had altered mental status with unknown etiology, just to say, well, the patient had an altered mental status, but really couldn't determine the cause, and the provider maybe just not feel comfortable with the diagnosis of TME. And of course, another response if none of the three options are satisfactory. So remember the query components. We started with the case summary. We provided clinical information, the treatment, and we asked a very specific question using multiple choice where there was clear and altered mental status, patient had sepsis, was there another diagnosis to explain that altered mental status, and if so, could they document TME? And just to review the best practices, we use complete sentences. We want to include positives and negatives. There's none in this case. We just included the positives. We only use specific information and no abbreviations, or try to avoid them when possible. And that's one of our examples to really go through some of the most complicated query, which is encephalopathy. Because a lot of times what happens is, so a patient comes in with sepsis and they don't have an altered mental status. Well, then you wouldn't even consider encephalopathy. But for how about all those patients that come in with encephalopathy? But now look what they had to do. They had to work up the patient for that altered mental status. They did a CT of the head. They had to evaluate to say, well, was there a stroke? So they're already expending more resources for this patient with an infection. The electrolytes were also off and they had to be corrected. And once they were, did then altered mental status improve? So really, you don't want to query every single patient who has an altered mental status and say, well, is that encephalopathy? You want to look to say, well, could it be explained by anything else? In this particular case, there really was not much explaining what caused an altered mental status except for the infection and the electrolyte abnormalities. And based on those two conditions, TME could be evaluated for this patient. So just think about that. All the patients that come in with sepsis, if they don't have an altered mental status, you really don't have a leg to stand on by querying for encephalopathy. But if there is an altered mental status, there's no baseline dementia, there's electrolyte abnormalities, and it's improved, and it improves after treatment, then those are the cases that you should consider querying and asking docs and say, well, TME is a diagnosis of exclusion. Do you feel comfortable in this particular case to include the diagnosis of TME? You want to really look at the whole picture and say, well, can we explain the altered mental status? If not, then maybe consider TME. But if there's a patient with a baseline of dementia, it's a little more difficult in those cases. So you'll want to just talk to your providers and say, does it make sense in this case? So thanks for joining and just listening to some of our ideas about how to approach encephalopathy and query strategies. If you have any questions, my email's there. It's bsayabovorn@providentedge.com. And again, thanks for joining, and I hope to hear you come on the next webinars.